Hey everybody, it's Eric Azel here again. I wanted to talk to you about some advanced EKG interpretation. We'll go through some basics and try to look at a few of the more rarely encountered 12 leads as well, and kind of go from there. So some of our objectives: review some basic interpretation fundamentals, how to manage some commonly encountered abnormalities, and a few zebras that may save someone's life someday. So the initial step, I always say, take a quick look and make an overall impression of what you see. And I said, is this immediately actionable? Don't sacrifice your check down process. And what I mean by this is, do you look at it and do you see, VTAC, something that you immediately need to take action on? Then after you've determined if it's immediately actionable, as you're preparing that action, you go through your check down process still. If you take a look and determine it's not immediately actionable, then you move on to your check down process, if that makes sense. I'm going to show you a couple pictures of obvious ST elevation MIs, and that's not the purpose of what we're talking about here today. I'll be honest, I feel like almost all of us who are doing and interpreting pre-hospital EKGs should be able to pick this up in a pretty easy manner. Obviously there are ST elevations significantly in V3 through V6 on this 12 lead. Another one, we've got a big ST elevation, 2-3 AVF. So we've got an inferior MI. There's what we call reciprocal changes, big ST depressions in V1 or V2. There's also a little lateral component to this MI as well. As you can see, the elevations in V5, V6. Again, I'm not going to talk about these in depth. I feel like these are ones that we should be able to pick up relatively easily and feel comfortable calling the cath lab on. So what is, when I say the check down process, what is that? And one of the biggest rookie mistakes I see is just reading the top interpretation of the machine and not going through it yourself in a check down process. And so the things you want to do is, number one, you want to look at the rate. Is it fast or slow? Then you want to look at the rhythm, regular or irregular. Do you see any signs of ischemia? So you want to look at your ST segments. What axis is the 12 lead? And that can give you clues as to where the site of pathology is if it's an abnormal EKG. Then you want to look for hypertrophy, and we'll talk about that. And then you want to look for any other morphology that might be relatively important to the patient's condition. I love this slide because basically what it does is it shows where how electrical impulse goes through the heart and what it represents. So, over here, ignore the U wave. That's just an extraneous thing. But as you go through a heartbeat, this is what follows basically the electrical conduction of the heart. So your P wave is atrial depolarization. Your QRS is ventricular depolarization. And then your T wave is your ventricular repolarization. So if you see abnormalities in your P wave, the problem is up in the atria. If you see it in your QRS, then it's down in the ventricles. So already, just by where the abnormality is in the shape of your EKG tracing, you're already getting important information as to where in the pathology, in the heart the pathology is. And like I said, I just like to turn this on its side because it kind of shows you, again, a little better how that impulse goes through the heart and what it represents. So, like I said, with your ST segments, that means there's an abnormality of how there's a depolarization and a repolarization because there's a portion of that ventricular wall that's infarcting and not responding like it should. And that's where you get ST elevation. So I think it helps you not to get overwhelmed by the shape of an EKG tracing if you start thinking about in terms of where the problem's actually at. So first, in your check down process, your rate and rhythm, always check for yourself and plot it out with the rhythm yourself to make sure it marches out. I don't carry calipers, nerdy to do so pretty much, but what I like to do is make a mark on a sheet of paper at every QRS and make sure that it marches out. And also do the PP intervals and the QRS intervals, because every once in a while you'll get a third degree heart block that looks pretty regular. Then you'll find that those PP intervals and QRS intervals aren't matching up at all, and so you actually have an AV disassociation. So what are we looking at here? Basically your axis. You want to think of it as a marker pointing to the side of the problem. In right axis deviation, it can be from heart position in the chest, pulmonary issues, right ventricular hypertrophy, or a weak dilated left ventricle. So, and then with your LAD, left axis deviation, you've got LVH, your left bundle or fascicle block, Wolff Parkinson White, or ischemia. So really what I think of it is right axis deviation is from the pulmonary side of the heart, left axis deviation is from your aortic and your stronger left side of the heart. And it's really important to know if that's a new versus old phenomenon. And so basically this is how you tell it. So you look at lead 1 and lead AVF, okay? Your normal axis, both lead, the QRS, will be upright in lead 1 and in AVF. That's a normal axis. In left axis deviation, they'll point away from each other. Lead 1 will have an upward facing QRS and a downward facing AVF. In a rightward axis deviation, lead 1 will go down and AVF will go up, so they point towards each other. So, and then if this doesn't happen very much, but if lead 1 and lead AVF are both pointing down, that's an extreme right axis. So remember, both 1 and AVF up is normal. Pointing away from each other, left axis. Pointing towards each other, right axis deviation. One thing I want to talk about, and this is all what we, a lot of times worry about from a pre-hospital side of things, is ischemia versus infarction. When you have ST elevation, you have actual muscle dying typically. So look at each lead, make sure you're measuring from the baseline of the lead when determining elevation. So find where those QRSs tend to come across and draw a line even, and that's how you can look at that ST segment to see if it's rising. We talked a little bit about this in those first 12 leads, but don't forget your anatomic breakdowns. V1 through V4 are anterior MIs, 2, 3, and AVF are inferior, V6 and AVL are lateral. Don't forget, if you see a deep ST depression in V2 and V3, that can be a posterior MI. So don't forget that side of things as well. Anytime you see ST depression in those leads, make sure that's a consideration. So you had infarction, tissues actively dying. The second step is ischemia, which is tissue at risk. So again, look at the lead baseline. See if it dips below that baseline. These are changes that are theoretically reversible with meds. So if you get them on a nitro drip, you give them a beta blocker, you anticoagulate them, sometimes you'll see those ST depressions resolve and you've removed that tissue at risk of infarction. So again, if it's in multiple leads, one thing you want to make sure of is if it makes anatomic sense. So like you don't, this is something that I should have mentioned in the infarction section as well. You typically only actively infarct one blood vessel at a time. And so you really should only see changes in the leads that reflect certain parts of the heart. So if you see ST elevation in every single lead, you need to consider something else might be going on, like pericarditis or something along those lines. Same thing with ischemia. Typically your whole entire heart isn't ischemic. You'll just see certain segments. So again, if you see it in multiple leads, see if that makes anatomic sense. These are your different types of ST depression, and that's something to look for. Sometimes these are great examples of that, but sometimes it's not as readily apparent. But an upsloping ST depression like this, see here's your baseline, so you draw your line across. There is some depression there, but it's kind of a looped depression. That's a 30 to 40% error rate of truly being ischemic. A horizontal, this almost always is ischemia. So when you draw your line across, you've got a horizontal line below your baseline there. And then your downsloping ST depression. So again, here's your baseline. Then you've got that downslope. There is an error rate, but it's pretty small. So watch for these two, especially the horizontal ST depression. So remember, upsloping can be an error. Horizontal, very low error rate. Downsloping, pretty low error rate. Now we're going to talk about some atypical ST morphologies that you can add to your checklist. Some of these can be kind of a needle in a haystack. They're things that you may only see once or twice in your career, but if you can remember them, it can save a life. First thing we'll talk about is something called Welland syndrome. And this is a deeply inverted or biphasic T waves in V2 and V3. And bear with me on this, I'll show you a picture that'll make a whole lot more sense of this. This is highly specific for critical LAD stenosis. Your LAD artery is your widowmaker. These are the ones that young people die from, so this is a big deal. Many people that have this Welland syndrome are completely pain-free at the time of presentation. So you may be getting an EKG for a totally different reason, or they may not be having any chest pain at all, and then you may see this. And if you catch it, you can actually refer them to a cardiologist and save their life down the road. If cardiac enzymes are checked when this is in place, they're usually normal, or if anything, just very minimal elevation. The problem is a lot of times when somebody has an abnormal EKG, everybody's knee-jerk reaction is to put them in for a stress test. Well, these patients don't do well, and a stress test can actually be fatal for them. So remember, Welland syndrome, deeply inverted or biphasic T waves in V2 and V3. So look at that right there, V2. See how that T wave, so this is your Q, or your P wave. Your QRS looks pretty normal. Then your T wave, up and down. See that? So kind of almost a yin-yang, up and down, V2, V3. So anytime you see that biphasic P wave or T wave in V2 or V3, that's Welland syndrome. And most of these people have very, very severe widowmaker disease and are essentially a ticking time bomb. And a lot of them will be asymptomatic when you get this EKG. Biphasic T waves. There's another picture. They're not quite as biphasic. They're a little bit. Here's your baseline. It goes up and then way down. But see how big and deeply inverted these T waves are? I mean, they're almost bigger than the QRS. So that's another type of Welland syndrome. So biphasic or deeply inverted T waves. Let's talk about hypertrophic cardiomyopathy. I think all of you have a little, at least a basic degree of familiarity with this. This is the one that a lot of the athletes will collapse on the sports field with. And again, something that we obviously want to catch before somebody becomes symptomatic. And basically what happens is some people congenitally have a very thickened septum in between their two ventricles, and they get an outflow tract obstruction that decreases the amount of blood that reaches the aorta, and the heart has to pump harder to overcome this. So what happens is when they're exerting themselves, like on the sports field, their heart pumps harder and harder and harder, and then these, at the molecular level, these ventricles are more susceptible to electrolyte abnormalities, so they've got a blood flow obstruction. The heart has to beat extra hard anyway. It's prone to arrhythmias, and then all of a sudden you're putting them on the sports field where, you know, they're consistently getting heart rates in the 180s to 200s. And that's why, as you can see, it's the most common cause of sudden cardiac death for people less than 30 years of age. So this is a picture of what it is. So basically this is a normal heart over here. You know, your left ventricle is what pumps blood out into your aorta to the rest of your body. Nice thin septum there. What you see here is you have a very thick septum, and so it's very hard for the heart to pump blood into this aorta. There's only that small little window here. And then remember what I said, these tissues are also more prone to arrhythmias anyway at the molecular level. So you've got a guy that's out on the sports field, he's running wind sprints, he's having trouble getting that blood through there, that heart's pumping harder and harder to try to get enough blood out into his aorta to perfuse, you know, his muscles that are exerting themselves. And all of a sudden, this promotes an arrhythmia in these muscles, and there's sudden cardiac death. So what you see, LVH number one, so you've got a big thickened septum. So again, back to what we talked about, if your problem's in the ventricles, you're going to see changes in your QRS. And just remember, there's a big, huge septum, so you're going to see big, huge QRS waves. And then you're going to see what they call dagger-like Q waves inferiorly and laterally. So let's look at that. And this is a cardiologist would throw a fit if I said this, but you start worrying about hypertrophic cardiomyopathy when your QRSs are so big that they're almost touching the segments above them. And see how in V5 it almost touches the V4 there. Just big, huge, tall QRSs there. Again, it's another picture of it, hypertrophic left ventricle. You know, again, you've got that outflow tract obstruction and risk of sudden cardiac death. So you get your Welland syndrome, you get your big biphasic or deeply inverted T waves in V2, V3. You got your hypertrophic cardiomyopathy with your huge QRS complexes. One thing that can look very similar to hypertrophic cardiomyopathy is what they call an LVH with strain pattern. And people with this isn't a congenital thing like hypertrophic cardiomyopathy is, so they don't get the arrhythmogenic muscle in their heart. They just get thickened heart muscle from hypertension or other factors. And so basically they get what's called a strain pattern, which means stress on the left ventricle can lead to an ST elevation, which is really, really hard to distinguish from a true MI. And see what I mean here? So they've got QRSs that touch each other. So you know you've got a big, thick ventricle. And then see how that's, especially in V3, V4, V2, quite a bit too. This is your baseline, so those look like true ST elevations there. That's very difficult sometimes to determine from a true MI there. The one thing I will say is that the QRS almost looks a little widened in some of these pictures, and a little wider QRS will a lot of times have a strain pattern with a little bit of elevation there. The other thing to look for is I'm always talking about reciprocal changes. Let me go back here. Always talking about reciprocal changes in 2, 3, and AVF. There's really no ST depression reciprocally, because you should have, if you have an anterior MI and these leads, 2, 3, and AVF should have ST depression, and you really can't call that there. It's another one where the strain pattern is really high. Look at that V2 and V3. These are some of the ones that if I see this in a patient, these are maybe ones that I'm faxing to a cardiologist to help me determine what the etiology is. So these can be really difficult. This is one that you may want to take some time to look at. Scarbosa criteria, that gets really technical and difficult. But basically that's how you tell if there is an acute MI in the setting of a bundle branch block. And that can be very difficult. So these Scarbosa criteria, 1, 2, and 3, can tell you that. We talked about your posterior STEMI. Those are deep ST depressions. We talked about your LVH. See how there's a little wide QRS with an ST elevation. We'll get to your hyperacute and your De Winter T waves here in just a second. We talked about Wellens. See, there's your biphasic T wave, and there's your deeply inverted T wave. So just a quick summary. One thing I didn't talk about on here was your shark wave T waves, and that's here. Look at those. Something's wrong. That looks very ugly. That's also highly suspicious for an MI. De Winter T waves, those are highly predictive of LAD occlusion. They should be considered a STEMI equivalent. SD depression with large peak T waves in the precordial leads, and they should be treated like an acute MI if symptomatic. So I'll show you those. See those? Big, huge T waves, especially in V2 and V3. I would be worried about hyperkalemia with those size T waves as well. So. Brugada syndrome, this is another important one to know. High risk of arrhythmia in a structurally normal heart. It's the number 2 leading cause of death in males under 40, just behind hypertrophic cardiomyopathy. This one's a little scary because the only definitive treatment is an AICD. This is another one that you may just pick up in a routine screening EKG or an EKG done for another reason, but it can save a life. So in order to be called Brugada, it must have EKG changes and then one of these things here. So documented episode of VFib or VTAC, family history of sudden cardiac death before 45, family members with similar EKGs, inducible VTAC with an EPS study, you're probably not going to get that history, syncope, or nocturnal agonal respirations. So when they sleep, have weird breathing basically. But Brugada type 1, you have what's called coved ST segments with V1 to V3 T-wave inversion. Type 2 has greater than 2 millimeters of saddleback ST elevation. And type 3 is shape of 1 or 2, but less than 2 millimeters of elevation. Again, this sounds way more complex than it is. Let me show you some pictures. So right there, when you call saddleback, right? So you've got one side of the saddle, the other side of the saddle, and this deep thing here. So saddleback. Here's another one, saddleback, right? And V1, V2, up, down, up, down, up. So just remember Brugada, saddleback. Same thing. So this is the other form of Brugada where you have it kind of up, and then see how it kind of, you got a ST elevation and then over. Don't forget your EKG changes of right-sided heart issues, your right bundle branch blocks, your RVHs, your right atrial enlargements. Make sure you pick those up, and those can clue you into pulmonary pathology. A lot of times these don't need a cards referral unless they're symptomatic, but I would consider pulmonary eval, smoking cessation, sleep apnea testing, things like that. If they're acutely symptomatic, consider pulmonary embolism or right-sided MI. So again, let's talk about my check down. Quick impression, rate, rhythm, axis, ischemia. Look at your morphology, your P, QRS, T waves. We didn't talk about Chamberlain's rules. Those get a little too in-depth for this discussion. And then your last step is your zebras, and we're going to go over those. One mnemonic I use for my zebras is how bad. And so what you have are hyperacute T waves. We talked about those, your De Winter's T waves, right? Your hypertrophic cardiomyopathy is your O. It's your big thickened septum. So remember, you get those huge QRSs that touch the QRSs above them. Wellens, so remember those, your biphasic T waves. So your T wave goes up and then down, or deep T wave inversions. Brugada, remember that's your saddleback. We didn't talk about the A, AVR ST elevation. When you see isolated ST elevation in AVR, a lot of cardiologists will tell you that cannot be an acute MI and that they shouldn't go to the cath lab. The studies have shown about 10% of these patients will have left main or left anterior descending artery occlusions. So, be aware of your ST elevations, and especially in a patient who looks bad or symptomatic, an AVR ST elevation should be treated like acute MI, similar to all others. And then your De Winter's T waves we talked about, which are your big hyperacute T waves that, especially in the absence of hyperkalemia, should be treated like an acute MI. And that's really it. Questions? Like I said, I always appreciate your feedback. Again, don't rely on the machine interpretation. Don't get overwhelmed. Try to, think about the different, your P wave being your atrial problems, your QRS being ventricular problems. Remember your how bad mnemonic. You might save someone's life by picking up a Wellens or a Brugada syndrome in somebody who's asymptomatic, or even a hypertrophic cardiomyopathy. So hopefully this was useful for you, and it'll help improve your EKG interpretation. And like I said, I appreciate all feedback. So thank you.